Good afternoon, and welcome everyone to this Translational Applications in Public Health lecture, which is a collaboration between the Institute for Public Health and Medicine and the Northwestern University Clinical and Translational Sciences Institute. I'm Roger Anderson, the NUCAT's Marketing and Communications Director. I want to thank everyone for joining us. During today's presentation, please use the Q&A function rather than the chat to submit questions. We'll have time at the end of the presentation for Q&A with today's speaker. Today, we welcome Brian Mustanski. Brian is Director of ISGEM and Co-Director of the Third Coast CFAR, and today he'll be discussing from discovery and implementation science to end the HIV epidemic. Thank you, Brian, for joining us.
Thanks, Roger, and thanks to IFAM and NUCATS for inviting me to present today. For those of you that are on Twitter, you can reach out to me on Twitter at Mustanski. I'm happy to kind of continue the discussion or answer any questions on Twitter if we don't get to them during the presentation today. So let me just start by introducing myself very briefly. As Roger mentioned, I'm co-director with Rich D'Aquila of the Third Coast Center for AIDS Research. And if you're not familiar with the Third Coast CFAR, I welcome you to go to our website and check it out. We have a number of services for HIV researchers at Northwestern. We also have the University of Chicago as a core partner and the Chicago and Illinois Department of Public Health, as well as a number of community-based organizations that are key partners in the Center for AIDS Research. There's seminar series, connection to pilot funding, core services, et cetera. So I encourage you to check that out if you're an HIV researcher or interested in getting started in HIV research. I also am the director of ISGEM, or the Institute for Sexual and Gender Minority Health and Wellbeing, which is the largest LGBTQ health research institute in the world. We're a university research center that spans many and nearly all of the schools at Northwestern. And our focus is really on connecting scholars from numerous disciplines with the sexual and gender minority community in order to foster collaborations and new research to advance the health and well-being of the LGBTQ community. If you're interested in learning more about ISGEM and our activities, you can go to the ISGEM website, click the contact button, and subscribe to our mailing list. We only send out one email a month, so it's not a lot to learn more about what's going on at the Institute. So one of the points I wanted to make today as I talk about translational research, specifically in my work focused on LGBTQ health and HIV prevention, is some of the differences in the approaches between the two institutes and centers that I'm very closely aligned with. So as I mentioned, the CFAR conducts basic clinical, translational, behavioral, and implementation science with a focus on HIV prevention and care across populations. So the CFAR is an example of a center that is disease specific. It's really focused specifically on HIV prevention and care. ISGEM, on the other hand, takes a different approach, which is that it conducts clinical, translational, and behavioral sciences on multiple health issues in the same population. And I think that these examples are really a complementary way of thinking about two approaches to studying health. You know, the disease specific might span multiple populations, and there's a lot of advantage of that disease specific approach because it can bring together researchers from different aspects of the translational spectrum and really make sure that you're doing the cutting edge HIV research across a variety of different populations. ISGEM, on the other hand, focuses on a specific population and studies multiple health issues. And one of the advantages of that approach is that you're really able to think about the culture of that community. You're able to build up partnerships with organizations that serve that community and really focus on the community in a holistic way. And so we can leverage the partnerships we have with over 20 different community organizations in Chicago that focus on the LGBTQ community. And within that, we do mental health research, cancer research, HIV research, et cetera. And my own work really sits at the interface of these two centers and institutes. My work focused specifically on HIV prevention and also a syndemic of health issues, including HIV, substance use, mental health, particularly suicide, among young sexual minority men who are the primary focus of my work, although in my career I've done work more broadly on the LGBT community in general. The reason that I focus specifically on young gay and bisexual men in my work is really the epidemiology of HIV really points us to that population as an important one, important priority population for HIV research. What you see here is the CDC estimates of HIV incidence in the United States from 2010 through 2018. And you can see that the majority of HIV infections in the United States are attributable to male sexual contact. And that number of infections has hovered around 24 to 26,000 infections every year in that population. Heterosexuals, including heterosexual men and heterosexual women, have hovered around 10,000 infections, so less than half the number of transmissions from men to men. And that number has actually gone down over this period by 20% from 2010 through 2018. So there's a major disparity, and actually that disparity may be growing over time. When we drill down more amongst the population of men who have sex with men, we see that younger populations are most impacted. So 25 to 34-year-olds actually saw a 27% increase in the number of diagnoses from 2010 through 2017. And we've seen the second largest group of 13 to 24-year-olds have stayed flat have not seen declines in diagnoses. This is despite some discoveries of really important prevention options like pre-exposure prophylaxis or PrEP. And so while we see that we have new prevention approaches, medications that you can take to prevent infections, we've learned that when people living with HIV are on effective treatment and get to be sustained in terms of viral suppression, they are essentially unable to transmit the virus. So treatment equals prevention, undetectable equals untransmittable. So despite these big discoveries in biomedical prevention, we haven't seen a decline in the number of HIV infections. And in fact, we're seeing an increase in these groups over time. Layered on that are racial disparities. We've seen over many years now that Black or African-American young men who have sex with men between the ages of 13 and 24 are really disproportionately impacted by HIV with over or around 4,000 infections every year. And Hispanic or Latinx young men who have sex with men are really one of the only groups that we're seeing an increase in the number of diagnoses overall. Now, given the fact that we see that young men who have sex with men have been disproportionately impacted by the HIV epidemic for well over a decade, you would think that this is a major focus of the development and testing of HIV prevention programs. What you see on the website, on the screen now, is the CDC's website where they diffuse or distribute interventions that have been proven to be effective at HIV prevention. The last time I reviewed this compendium of interventions, there were 93 CDC-endorsed evidence-based HIV risk reduction programs. A little more than a quarter of them, or 25 of them, were for youth and adolescents. But only 2 of them were for young adult men who have sex with men, and 0 of them were for men who have sex with men under the age of 18. So we really see that despite the fact that this is a population that has been overly impacted by the HIV epidemic for a long time, we really don't see the research and prevention response representing the face of the epidemic. We also know that there's challenges for community organizations to obtain federal funding for HIV prevention unless they're implementing one of these effective interventions. And so this creates the situation where we've had a lack of science historically on HIV prevention in adolescent, particularly MSM, which means we have a lack of evidence of effective programs. That lack of evidence means we have a lack of access to funding for HIV prevention programs and a growing epidemic. And this is what my colleague Hendrix Brown has described as a scientific inequity driving a health inequity. So really focusing on this population of adolescent and young adults, particularly around HIV, has been the focus of my career for the last 20 years. And one of the things that focusing on this population for so long has really allowed me to develop this full portfolio of translational projects across the spectrum, from studies that really focus on basic questions of epidemiology. What is the rate or the incidence of HIV in this population? what are some developmental processes and mechanisms that explain why some individuals are more likely to be infected than others? What are structural characteristics that drive those disparities? To developing interventions and pilot testing or demonstrating the acceptability and some preliminary effectiveness of those interventions, to then full-scale effectiveness trials demonstrating and testing the effectiveness of HIV prevention programs with this population. Now through to implementation science and conducting implementation trials where we're really studying, now that we know an intervention works, how do we get it implemented at scale? And one of the points that I'd like to make is that there really has been for me, and I would say some of these are my projects, some of these are projects that I collaborate on others with. Together, for example, is an intervention led by Michael Newcomb, who's a faculty member at Northwestern. That's an intervention for young male couples that I'm collaborating on. Others are ones that I lead or collaborate on. And one of the things that I want to say that's really been a huge benefit of having projects across this translational spectrum at the same time is that the projects can really speak to each other. You know, the basic studies, the observational mechanistic studies are identifying populations at risk. They're identifying risk and protective factors across development. And within our own lab, within our own team, within our own institute, we're able to take that intervention, that information and use it to inform interventions that we're developing and studying how to implement. At the same time, the interventions that we're delivering raise new questions about how, how could we make them more effective? How could we reach other populations? What are emerging trends that we need to address? And so the interventions then speak back to the basic studies and the observational studies. And there's this real synergy across our portfolio of projects within the Institute. I think the other reason that it's particularly important to really have projects across this translational spectrum within your own team is that, many of us were trained in graduate school that you might take a slice of this translational spectrum and work on it. If you're developing, or testing an intervention or studying a mechanism, somebody else will someday, take that information and create an intervention, or somebody else will figure out how to scale that intervention. And I think what we find is that a lot of things fall off this translational spectrum because there is no one necessarily waiting to pick up the next step of the work. So if you're really passionate about the population or the health issue, sometimes you have to take it upon yourself to move the work along the full translational spectrum. And for me, that's been really incredibly rewarding. So I'll talk a little bit about some of the projects, just kind of giving snapshots of some of the projects that I have along this translational spectrum. RADAR is an example of one. This is a longitudinal cohort study of over 1,200 young men who have sex with men, transgender women, and non-binary individuals who are assigned a male sex at birth, that we've been following, some of them for over 15 years since they were teenagers living in Chicago. And RADAR is a multi-level study where we're studying not just the individual characteristics, but really looking at it from the biology of the HIV virus, systemic inflammation, interactions between the virus and the host, as well as looking at individual development, where we've been following these young people across their lives as they've been growing up and looking at developmental processes. We enroll romantic partners into the cohort as well and follow them over time. So we have dyadic data on the participants. We also have been doing network science over the last 7 to 8 years in this population. That's really allowed us to work on system science methods to understand the drivers of disparities to help inform modeling studies of the implementation of different interventions within this population. And then finally up to looking at neighborhood characteristics, structural factors that drive disparities. And you can see, this kind of multi-level project really requires an interdisciplinary team of co-investigators. Amongst them, mention a couple of people at Northwestern, Michael Newcomb, who oversees the psychosocial and statistics methods for the study, and Rich D'Aquila, who oversees the biomedical aspects of the study. And then also Tom McDade in anthropology, and Pat Janulis and Sanjeev Shah in cardiovascular, who's helping us understand early markers of the potential development of cardiovascular disease in the population. We take a syndemic framework within this work, so we're really looking at the interplay between mental health, substance use, and sexually transmitted infections. This is an example of a paper that just recently came out, led by one of our postdocs, Casey Xavier Hall, looking at how substance use, particularly stimulant use and heavy use of marijuana, predicts sustained viral suppression in this community-based cohort of sexual and gender minority young people living with HIV. HIV incidence is very high in this sample. Our HIV reports of HIV incidence shows that in this group, it's really one of the highest rates we see in the world in terms of number of new infections year by year. And we're really interested in what are the supports, what are the characteristics that help support individuals who become infected with HIV, sustain viral suppression. And then we're really using this intervention to inform interventions around treatment engagement, testing, linkage to care in this population. Now I want to switch gears and talk a little bit about some of my intervention work and some of my implementation science work. And this portfolio of work that I've been doing for the last 20 years really has been informed by this question of how do we reach gay and bisexual adolescents and young adults with HIV prevention. This is a population that historically has been hardly reached with interventions. And because of that, sometimes we don't have great understanding of how to even reach this group and work with them. And I was really impacted by a study led by a community organization with this report that came out in the late 90s, showing that the majority of LGBTQ young people were coming out online before they were doing so in the quote real world. Of course, in the 90s, you know, when we had dial-up internet, the life that you might lead online, the time that you spent online was really separate from your offline time. That's obviously quite different now with the internet in your pocket on your cell phone. But that really impacted me to think, if we could reach these young people at this critical developmental period where they're coming to understand their own identity, they're beginning to share their identity with others, you know, we might be able to actually use the internet as a means to reach them with education and services and supports, really even before they enter this critical period of coming out. Using the internet also allows us to reach youth directly instead of having to go through organizations that might might mediate the message that we're trying to deliver. So for example, certain states still have laws on the books that say what we call no promo homo laws, which is that if you talk about homosexuality or LGBT individuals, you have to do it in a negative way that explicitly says that this is a mental illness, that it's not approved of by society. And you can imagine in those 5 states where that's the message that the school system is sending, that it would be really hard to do effective education that would be accepting and affirming of these young people. And therefore, doing it online allows us to reach these young people directly. So historically, the pathway of developing and testing HIV prevention interventions has been doing formative, qualitative research, understanding the population, developing an intervention, pilot testing it for feasibility and acceptability. This might be an R01 or an R21 that does the formative research. You might get some kind of intervention development grant like an R34 to develop and pilot test the intervention. You then might apply for funding like an R01 to test the efficacy or effectiveness of the intervention. It then might get classified by the CDC as an evidence-based intervention in that compendium that I mentioned before, at which point you might be able to get funding to package the intervention. That might lead to some kind of dissemination and training support for the intervention and allowing organizations to apply for funding to implement the intervention. This process is a long road from the science to the clinical or preventive intervention delivery. And this is why, you know, it's frequently stated that it takes 17 years from discovery for an intervention to reach widespread clinical practice. And, you know, so I'm going to talk a little bit about some of the types of approaches that we've been using that can help accelerate this process from discovery to implementation. And one of these is the use of what are called hybrid trials. And these types of trials sort of combine some of the features of an effectiveness study with some of the characteristics of implementation research. So on the left at top, you see clinical effectiveness research, which is really just designed to say, does this intervention work? Often under very ideal characteristics, under ideal situations. And then on the right of the screen, you see implementation research, which is, we know this intervention works, we're just purely studying how to implement it. Hybrid trials sit at the interface of these two. And there are several different types of hybrid trials. On the bottom left, you see type 1 trials. Those are trials that are still really focused on testing the effectiveness of an intervention. But while you're doing it, you're gathering information about future implementation. So you might be getting data on acceptability amongst the target population. You may be estimating the cost of intervention delivery. You may be doing interviews with key stakeholders who would be involved in the implementation of the intervention. On the other side, we have hybrid type 3 trials that are studies where you're really studying the implementation, you're testing strategies for the implementation of the intervention. But while you're doing that, you're still collecting data on the effectiveness of the intervention. And you might do that because as you scale up the intervention to more settings, you might be concerned that there could be a, quote, voltage drop where the intervention becomes less effective as it's scaled up. You might be moving it into new populations, new communities, new delivery systems. And so you want to continue to observe the effectiveness of the intervention while you're scaling it up. And I refer you to the work of Curran, who has written a number of papers outlining these types of hybrid trials. And I'm going to give you examples of one of my interventions studies that's a hybrid type 1 and one that's a hybrid type 3. So the hybrid type 1 that I'll talk about is the SMART trial. This is a U01 grant funded by the National Institutes of Minority Health and Health Disparities. And this is a stepped care suite of 3 online HIV prevention, sexual health education interventions for adolescent men who have sex with men between the ages of 13 to 18. And because it's a hybrid trial, we're really focused on establishing the effectiveness of this package of stepped up interventions. But while we're doing that, we're collecting data to inform future implementation. We enrolled 1,268 adolescent men who have sex with men. It's a very diverse sample, really enriched with Latinx participants, with African-American and other populations. We did intensive outreach to Native American communities, Pacific Islander communities, Asian communities to really reach them as we were developing and testing the intervention. Because this is such a large project where we're collecting so much diverse kinds of information, this is also one that requires a team science approach. And you can see the list of co-investigators, and I'll just name the folks at Northwestern. Catherine McCapagal, Michael Newcomb, Dennis Lee, Hendrix Brown are all key collaborators on this project. I'll say in this intervention, as I said, we've enrolled 1,268 participants. We had representations from every state and Puerto Rico, with the exception of Wyoming. That was the only state that we didn't have anyone enroll from. If you're interested in reading more about this stepped care e-health approach, this is our protocol paper for the evaluation of the SMART package of interventions that was published in JMIR Research Protocols. And as I mentioned, this is a hybrid trial, so our primary focus is on determining the effectiveness of SMART as a package of interventions at reducing sexual risk, improving intentions to use condoms when sexually active, also improving intentions to use PrEP or to take PrEP, and also to engage in HIV testing. I'll come back to testing again in a minute. And then our secondary focuses are really these implementation questions about the acceptability of the intervention package to adolescent males who have sex with males. We've done interviews with community-based organizations about our dissemination ideas, barriers and facilitators to adoption, and we're also estimating the cost of delivery, really using these mixed methods approaches. As I mentioned, SMART is a stepped care intervention, and that really follows the kind of public health approach of thinking about interventions that are universally delivered, meaning regardless of risk, this is an intervention that can be universally delivered to a particular population, selective interventions, and indicated interventions. So selective interventions are for individuals who might be at higher risk, particular reasons to think that there might be more need for interventions in that population. Whereas indicated interventions are individuals who might already be engaging in behaviors that put them at risk, or having some symptoms of a particular disease or early onset of a disease. There might be reasons to think about more intensive intervention. And so this is a SMART trial, which stands for a sequential multiple assignment randomized trial. So all of the participants in the SMART trial get sex education. It's an adaptation of an intervention we call queer sex ed. Those who don't respond to the intervention get randomized to either an intention control or a more intensive intervention called Keep It Up. Those that don't respond to Keep It Up then are randomized again to, again, a more intensive indicated intervention called, originally called the Young Men's Health Project, which we've adapted for this population. So really the idea is, what's the right package of interventions? How do we use resources in the most cost-effective way to deliver the kind of minimum dose of intervention that you can to sort of provide effective HIV prevention to this population? And what we did is we started with 3 interventions. This really followed the information, motivation, behavioral skills model of health behavior change, where we have the first intervention is sexual health education. That's really providing information and facts about HIV, sexual health, sexual minority identities. And we adopted an intervention called queer sex ed for young MSM. Then we have these more intensive interventions, an adaptation of the intervention called Keep It Up that we call Smart Squad. And then the most intensive intervention is called Smart Sessions, where we actually have motivational interviewing coaches who meet with the participants over video chat and really address their own particular challenges, motivational, logistical, around engaging in HIV prevention. This slide shares a little bit about how we developed the intervention. We have a multidisciplinary team of experts in learning sciences, software development, public health, graphic designers, psychology. We had a youth advisory board that gave us feedback on the content as we were developing it to make sure that all the visuals, the storytelling was appealing to this population, as well as really making sure that we're addressing the kind of issues that they bring up that are central to their lives. So you can see sort of how we worked with young people to develop the logos. They really encouraged us to use emojis as part of the content, and really to address the use of social media as it's relevant to their lives. As we were adapting content, you can see that, for example, the original Queer Sex Ed had this thermometer where individuals would drag sexual behaviors onto the thermometer to estimate how risky they were in terms of HIV transmission. And then as we updated that in 2018, it became a calculator because we knew that most participants would be using this on a phone. And so it had to be touch responsive. We integrated the emojis as the participants had encouraged us. And as you type in the behaviors that you're engaging in, as well as the risk factors like having a sexually transmitted infection, if your partner is not virally suppressed, living with HIV, using a condom, using PrEP, it actually gives you an epidemiologically valid estimate of your HIV transmission risk and how to, and then you can change the behaviors to see how the risk goes down. Dennis Lee published this paper in Prevention Science that talks about the use of this intervention mapping approach to developmentally adapt this risk reduction program for this age range. The original interventions were for young adults, and we developmentally adapt them for adolescents. We also linguistically and culturally adapted all of the content in partnership with my colleague, Carlos Rodriguez-Diaz, who was formerly at the University of Puerto Rico and is now at George Washington University. So all of the SMART content is developed and available in both English and Spanish. And we had recruited monolingual Spanish participants to evaluate the intervention. As I said earlier, we partnered with different minority and diverse communities to really understand the needs of these populations, how to reach these populations. This was really new work reaching adolescents. And so there wasn't a lot known, for example, about how to reach Native Hawaiian or other Pacific Islander youth. And so through a supplement that we got to the grant, we were able to partner with Misty Pachenko, who's a professor at the University of Hawaii at Hilo, to do qualitative interviews with young men who have sex with men to understand how to reach that population. We also had a diversity supplement for Melissa Marzan Rodriguez, who was originally at University of Puerto Rico and is now at Ponce Health Sciences University, to study the implementation of Spanish language HIV prevention programs for Latinx adolescent MSM. And one of the things I would really point out is that these sort of supplements have been really key for us to help grow the community of minority health scholars from diverse communities. And if you don't know, if you have an NIH grant, you're eligible to apply for a diversity supplement to bring on a minority scholar to join your research team. And I've done this for most of my grants over my career. I really encourage you, if you're NIH funded, to think about applying for one of these diversity supplements. And I recorded a video for the Third Coast CFAR that explains the process of how to apply for a diversity supplement. And that video is available on the NewCats website. All right, so now I'm going to give the example of the type 3 trial. This is a large R01 grant that was funded by NIMH, NIDA, and the Office of the Director through the Office of Behavioral and Social Science Research to study the implementation of an effective eHealth HIV prevention program, in this case, an intervention called Keep It Up. Again, requires a very multidisciplinary team of researchers across Northwestern, the Institute, the Third Coast CFAR, the Center for Prevention Implementation Methodology, as well as this center in New York called Cherish that's really helping us estimate the cost and cost effectiveness of the delivery of this intervention. And in fact, our primary outcome of this trial is public health impact, which is defined as the reach of the intervention multiplied by the effectiveness of the intervention as measured through behavior change and reduction in sexually transmitted infection. We're also explicitly testing the cost effectiveness of this intervention. And I'll talk a little bit more about some of the outcomes in a second. Keep It Up is an example of one of those interventions that really went through this multiple phases of intervention, pilot testing, development, and testing of effectiveness, and now finally really focused on the implementation of these eHealth interventions. But one of the things that I specifically wanted to point out is that we often use this braided funding model. So while NIMH funded the initial R34 to develop and test the intervention, CDPH then funded this intervention to our community partner, Center on Halsted, as a homegrown intervention that was actually delivered to over 600 young men who have sex with men in the Chicagoland area. And while it was being delivered, our team was evaluating it. So it allowed us to begin to understand implementation in a real world setting and to continue to collect data on the effectiveness of the intervention. Then we did a full-scale 3-city effectiveness trial. As that was wrapping up, ViV Foundation funded us to implement Keep It Up as a service, primarily focused on Black young men who have sex with men in Jackson, Mississippi, again being delivered by the Jackson Medical Mall, which is a community-based organization. So as we've been studying and demonstrating the acceptability, the preliminary effectiveness, the full effectiveness of the intervention, we've been also working with community organizations to implement this as an intervention along the way. And that's really been valuable to us to understand the implementation of such an intervention. I will say Keep It Up has, in the R01 where we tested it in Chicago, New York, and Atlanta, we found the intervention to be highly effective. It produced a 40% reduction in sexually transmitted infections over a 1-year follow-up period. We were testing those sexually transmitted infections, so it wasn't self-report. This was one of the first eHealth interventions to show an effect on a biomarker. And we also found that it was most acceptable, most engaging with Black young men who have sex with men in the South, the population that's been most impacted by the HIV epidemic. Keep It Up then got classified by the CDC as as a best evidence intervention for reducing HIV risk. And now in this new R01, our team is studying how to implement Keep It Up. And the way that we're doing that is we selected 66 counties that have high HIV incidence and large numbers of young men who have sex with men between the ages of 18 and 29. We then randomized those counties so that they would have one of 2 possible strategies for implementing Keep It Up. The first was a traditional strategy for the delivery of effective interventions, which is that in 44 counties, we opened up a request for proposals where community organizations could apply to Northwestern for funding to implement Keep It Up amongst individuals getting HIV testing within their community-based organization. And then in another 22 counties, we're delivering Keep It Up from Chicago in what we call a direct-to-consumer strategy, where we actually do all the recruitment. We ship an HIV test kit through the mail and an STI test kit through the mail. We deliver the intervention, and all of that is done from Chicago. And we're really comparing these strategies in terms of which one reaches populations most at risk for HIV, which one's more acceptable, which population is more likely to complete the intervention. And you can see some of the outcomes that are from this RE-AIM framework, which is a really important framework for understanding the implementation of interventions. I will say that due to COVID, we've had to make a number of changes to this design that I just described. I'm not going to go into those today. Happy to answer questions about that during the Q&A. Finally, I want to wrap up by talking about a little bit more about some of the implementation work that we're doing. Some of you may know that the president announced a plan for ending the HIV epidemic. Our former president developed a plan for ending the HIV epidemic by 2030, with a goal of having a 75% reduction in new HIV cases by 2025. This is a federal agency-wide across the Department of Health and Service departments to really work together and coordinate initiatives to end the HIV epidemic. The NIH's role in this is to develop best practices and identify best practices of strategies to implement effective interventions. And therefore, NIH has put funding through the networks of Centers for AIDS Research to partner with local community organizations to develop and evaluate and understand strategies for implementing effective interventions. Our Third Coast Center for AIDS Research was selected to be a coordinating center for this Ending the HIV Epidemic initiative, which I co-lead with Nanette Benbow, who's a faculty member in psychiatry. And you can see our team, our really fabulous team for what we call the ISKI initiative. And the goal of this coordinating center is to really try to understand, first of all, we support the projects. We've done workshops, trainings, we distribute educational material about implementation science. We do technical assistance with projects. So there's this component of ISKI that's really focused on supporting these implementation science projects. The other part is for us to coordinate the work across these projects so that what is local knowledge, what these projects are learning as they partner with community organizations, if we can collect that data in a systematic way across this now nearly 100 projects that are taking place, we can begin to create generalizable implementation knowledge from this local knowledge. So that's really the ultimate goal, is to move from this sort of learning about implementation practice through the use of implementation research methods to begin to understand generalizable knowledge about effective strategies. We're in our second year for the ISKI Center, and in year one, NIH funded 65 projects that were partnerships between Centers for AIDS Research and AIDS research centers and community-based organizations and health departments. We were the one coordinating center that was funded, and we provided all of the implementation science consultation, coaching, webinars, and support to projects, as well as coordinated data collection. In year two, NIH funded 34 projects, some of which were funded for 2 years this cycle. And they also added 5 regional hubs that provide support to these 34 projects, which has been really phenomenal for us, because with the hubs doing the coaching and supporting of the projects, ISKI has been able to shift our focus to more on coordination. And we've been doing a lot of work on the harmonization of measures across projects. We've also started to do training and support for the partners around implementation science. And we still lead these fishbowl activities that go across all of the projects, across all the hubs that are working on similar issues like PrEP in certain populations or rapid delivery of ART. We're also doing a lot around systematic reviews of effective strategies, as well as barriers and facilitators of the implementation of effective interventions. Here are the 5 hubs that are funded at Johns Hopkins, UCLA, CIRA at Yale, University of Alabama, and San Diego. And this forms an executive committee that works together between ISKI, which is the coordinating center, and these implementation science hubs. You can see these projects are really scattered across the EHE jurisdictions, this 34 from this round, and really are addressing both all of the pillars of the Ending the Epidemic plan, which includes diagnosis, treatment, prevention, and responding to outbreaks. And many of the projects are focusing on multiple pillars, which really represents this shift in HIV work from kind of segmenting prevention and treatment to a more integrated model. You can see this paper that we published, I believe, last year in AIDS and Behavior. That was a landscape review of the NIH-funded HIV implementation research. So if you're interested in learning more about what NIH has supported in HIV implementation research, you can check that out. And in the coming year, we're editing a special issue of JAIDS, the Journal of AIDS, that is focused specifically on HIV implementation science to inform the Ending the Epidemic initiative. And we're going to have more systematic reviews in that focused on, as I said, barriers and facilitators, implementation strategies, as well as opportunities for each of the projects to write about what they've learned about implementation of effective interventions. If you're interested in learning more about implementation science, specifically in HIV, you can check out the Third Coast Center for AIDS Research website. We have a public-facing website where we've recorded webinars and many of the resources across the various phases of work that our CFAR has done on HIV implementation science, including a number of meetings with real experts talking about core things like measurement, selection of outcomes, strategies, models, and frameworks. You can also go to the ISKI website, the link is above, where we've also started to make many of the resources that we have available to these projects publicly available. So it's a real rich compendium of materials about strategies, theories, science practice partnerships, adaptation of interventions to new population, as well as videos from the summit that we hosted. Finally, I just want to also invite you to be aware of the National LGBT Health Conference, which is a conference that ISGEM has organized with our community partners over the last 6 years. Last time we held it in Atlanta in partnership with Emory University, and it has really become the leading national conference focused specifically on research on the health of the LGBTQ community. Originally, we planned on having it in Chicago this May. We've moved it to an online conference, and you can go to the ISGEM website to find out about registration. If cost is a barrier to attending, we have fee waivers. We really want to make this a conference that's available to everyone, so please check that out. And let me just conclude by thanking the funders of this work that I've described today, the various NIH institutes that have funded our work, and to really thank my team of faculty at Northwestern, our amazing staff. Really, none of this work would be possible without the amazing team that I'm just so privileged to get to work with every day. And with that, I will take some questions.
Thank you, Brian, for that great presentation. We have a few questions that have come in. The first couple in regard to the SMART study. So for the SMART study, what implementation framework did you use as a theoretical model? CFAR, RE-AIM, and how did you choose?
Yeah, that's a great question. So in the SMART study, we really were combining across 3 different models and frameworks that are used in implementation science. So one is called EPIS, which is really focused on the stages of implementation, whether you're exploring, preparing to implement, you're actually implementing, or you're really thinking about the sustainment of an intervention. Because SMART was a type 1 hybrid trial, we were really focused on exploring the implementation. We weren't implementing an intervention in a pragmatic way, we were exploring. So we used that EPIS model to think about what are the research questions that we should be investigating around future implementation of this intervention. We then used CFAR to guide our interviews with community-based organizations, AIDS service organizations. We've also now been talking with teachers and schools and think about how they select health education interventions and how something like SMART could be integrated into a school health education program. And so CFAR has really helped us think about the barriers and facilitators at the organizational level for the implementation of an intervention like SMART. And then finally, REAIM is a model for selecting implementation outcomes. And we use the REAIM framework to really think about what are the right implementation outcomes that we should be collecting at this phase of the research. And so in that case, we're really interested in the acceptability of the intervention to the target population, reach, and for us, because everything we do is really driven by an equity perspective, we're very interested in reach to minority populations that are disproportionately impacted by HIV. And equity is a really important implementation science characteristic. And so that was a really important driver of our thinking about how we should frame our outcomes as well.
Thank you. Do you know the backstory behind using the owl for the logo as part of the SMART project?
Yeah, well, our team actually developed that owl as the logo. And as we were mocking up different logos for the project, we were thinking about what's sort of an image or a graphic that really conveys this idea of somebody being smart. So SMART has two meanings. One is really about the sexual minority population that we're focused on. And then there's also the sequential multi-phase adaptive randomized trial, both of which are SMART. And then we also thought about, how do we convey the idea to our participants that they're being smart by learning about their sexual health? And so we workshopped a bunch of different images, and then we started sketching them. And we showed them to our youth advisory council, and they really worked with us to say, the first bow tie had too much rainbow. We made it look slightly different, and continued to tweak it. And as you can see, as you might have seen on that slide with our Spanish language, I think we can share my screen again. You can see that the owl has really become a key fixture in the project, and we actually had a plush version of the owl made. You can see one of our staff standing in front of our offices here in Chicago. We also took the owl with us to Puerto Rico when we were doing outreach in San Juan at San Juan Pride. And actually, we've had many participants write to us saying, instead of a subject payment, could we send them an owl, which we couldn't do. But, I think it's just a good example of when you think about branding and marketing and intervention, how do you have people sort of recognize it? So when they're logging in, they know where they are, they sort of build an identity around it. One of the other things that participants can do is they, when they go into the forum, because we want participants to stay anonymous and not identify themselves to each other, they actually get to create their own owl, and they get to design it looking like, there's different pop culture references where we have different versions of owls, and they can use that as their sort of avatar for the intervention. And we call the owl Alejandro.
Very nice. Thank you so much. I just wanted to remind everyone to use the Q&A function for questions that you can submit to Brian. How does the wide availability of PrEP get factored into the intervention programs?
Yeah, so that's a really interesting question in a lot of ways. So one of the things when I talked about the Keep It Up series of projects, we were actually in the field with the RO1 for what we called Keep It Up 2.0, which was this 3-city study of behavioral HIV risk reduction, really focused primarily on condom use as a prevention strategy. We were about halfway through the delivery of the trial, enrollment into the trial, when PrEP got approved by the FDA. And we really had to do a lot of thinking about what does it mean to change the content of the intervention midstream to begin to think about addressing PrEP. Now, at that time, PrEP was FDA approved, but still wasn't very widely available. And so we quickly added some content to the intervention to educate people about PrEP with a little bit of information about how to get it, certainly about how effective it was, but it still wasn't really widely available while that trial was happening. Obviously, then as we move to these next phases of SMART and Keep It Up, PrEP has become much more widely available and accessible. And so, we do a lot of education around PrEP, motivation of PrEP. Many of the soap operas that are included in Keep It Up have characters who are talking about going on PrEP, staying on PrEP. And really, one of the things that's unique about Keep It Up is it's not just HIV education where we say, here's HIV is a virus, and here's how it's transmitted, and here's PrEP, and here's why you should take it. But instead, it's really about integrating these prevention options into your life. So each of the modules of Keep It Up is really about a different setting or experience in the lives of young gay and bisexual men. So there's a module on dating, there's a module on going to bars and clubs, there's a module on using apps for hooking up or dating. And we talk about how to integrate condoms and PrEP use. into those experiences in a way that participants tell us is very realistic and really true to their life. It's not preachy, it's not lectury. So, the availability of PrEP is really important for us. And it's one of the things that we think about, as we deliver an intervention, when the landscape changes, when the facts change, you have to change your intervention. You can't leave it the same and sort of ignore something like PrEP, even though you're in the field with an intervention that didn't talk about it, because the world changed. And so you can't sort of set it and forget it when it comes to these e-health interventions. Some of the tools that we have PrEP navigators, where within the intervention, participants can put in their zip code and see a map of PrEP providers in their area. We also educate them about PrEP assistance plans. For the young people in SMART, we educate them about what PrEP is, about the fact that it's now FDA approved for teens to take PrEP. That was a change that also happened in the middle of the trial. And we also help young people think about how they could talk to their parents about PrEP, how they could talk to their doctor about PrEP. We still see very low rates of PrEP use in teens. There's still a lot of barriers for teens to get on PrEP. And that's something that we're really focused on within the Institute. Catherine McCapigal, for example, is partnered right now with the AIDS Foundation of Chicago to adapt their PrEP for Love campaign for teenagers and really study how to developmentally adapt it and make it relevant to diverse young people.
How applicable do you think these approaches are in other settings or countries and in the context of global health?
Yeah, I think that one of the things we know is that cell phone and data plans on cell phones are something that's really taken off across the globe, that, in many countries, they sort of skipped the dial-up internet or the Ethernet phase and went right from something that was like dial-up to people having internet on their phone as their predominant mode of access. In certain parts of the world, while you might have internet on your phone, sort of data plans can still be a challenge. And so that's one of the things that we have to think about when we're developing our content, is to really make it responsive to the platform. So within the Institute, within ISGEM, we have a research team called RAD, Research Application Design and Development Team, led by Rana Saber, who really are experts in software development, the development of e-health interventions. And so one of the things they do is they develop all of our interventions as web apps, which means instead of downloading an app to your phone, you actually go to a web browser. And that's, we think, really important actually for young people and their privacy. It also makes it a little more accessible. We don't have to go through the iTunes store to make the, whatever it's called, the Apple App Store. So, I think, but when you think about a country maybe where data plans are more of a challenge, recently, Michael Newcomb and I and Nanette Benbow have been doing interviews in India and in Mexico about the delivery of some of these e-health interventions in those settings. And one of the things they said is in those settings, apps actually might be better, because when you're on Wi-Fi, you could download all the content and then interact with it without having to use up your data plan on your cell phone. And so I think as we think about different global settings, those real practical issues about really how do people get to your content are really important, and really an important consideration when it comes to implementation.
Thank you for that. Do you incorporate HPV vaccination education or delivery in any aspect of your work?
Yeah, thanks for that question. Absolutely. So the SMART program does have education in the first phase, the sexual health camp education piece, about the importance of HPV vaccination. We also, one of the things that the Institute, one of the things that ISGEM really prides ourselves on doing is reaching out to folks across the Northwestern system who might be experts in a real particular health issue but have never applied that work to the LGBT community. And we really welcome folks reaching out to us and having a dialogue about how they can take their work and apply it to the LGBT community. And HPV is a great example of that. There was a faculty at Northwestern, Mary Gerand, who was an expert in HPV vaccination. She'd done it primarily with young women, and she was interested in applying it to young gay and bisexual men. So we worked with her to collect some preliminary data in the context of one of our ongoing studies. She got a publication in a top tier vaccine journal, worked together with us on an R21 grant to NCI to adapt some of our text message programs to address HPV vaccination. The grant actually got a perfect score on submission and got funded by NCI. And then we worked in partners with our community-based organizations, in this case, the Chicago Department of Public Health and Howard Brown, to recruit participants to develop messaging around HPV vaccination. And that trial has just recently wrapped up, and we're looking forward to sharing some of the results from that. But I think HPV is a really important example of something where we have an intervention that really works, but we still see that, you know, only about a third of the young men who have sex with men in our research studies have actually received all the doses of the HPV vaccination. So that cancer prevention is a really important thing for us to think about how we can scale up that effective approach.
You talked about your past adaptability, you know, in terms of when PrEP came on and things like that after you were already kind of in the field. Can you talk a little bit about how COVID has affected the research you're doing?
Yeah, I mean, I would say in many ways. I mean, in some ways we were fortunate because at least SMART and Keep It Up were both two e-health interventions that were already being developed, delivered remotely. But, you know, our 22 community-based organizations that we funded to deliver Keep It Up, many of them had to close their doors during the height of COVID, weren't able to do HIV testing. So enrollment in that arm, you know, really lagged. Obviously, that was our primary strategy for that delivery, was to work with these community-based organizations. We're in very frequent monthly dialogues. We have forums with the community-based organizations where they're able to share a little bit about the ways that they're reopening, the ways in which they're using online recruitment and even at-home HIV testing within those organizations. Similarly, we found that we thought, wow, you know, the at-home HIV testing strategy that the direct-to-consumer arm was doing is going to fly off the shelves. You know, everyone's at home. You know, maybe they want to get an HIV test every 6 months, which is the CDC recommendation for men who have sex with men. But now they're at home, they can't get into the clinic, we'll ship it to them in the mail. And one of the things we found is, like, people were really fatigued of being on their computer. Like, many of us spend all day on Zoom, we're on our computers, it's really our gateway to the world. People kind of didn't want to spend any more time on their computer. And so the idea of actually doing an e-health intervention kind of dropped in appeal for a while. And we're still kind of studying that and understanding what that was about. How do we motivate engagement in this time? The Institute also really scrambled to work with researchers across Northwestern on bringing our expertise in e-health and health equity to COVID research at Northwestern. And so we're a core part of the SCAN study, which is doing COVID antibody research. And our team has really worked on engaging minority communities across Chicago to participate in COVID research. And there's a lot of papers that are now coming out of that SCAN study. And that's been really, I would say actually engaging in that study has been one of the highlights of my career, of working with virologists and pharmacologists and geneticists and human biologists, and really bringing our behavioral science to the table. You know, definitely, I would say, look forward to a lot of those publications coming out from SCAN in the near future.
I want to thank everyone for joining us today. I do see one additional question in the Q&A that I will forward to you, Brian, cognizant of your time. And on behalf of NewCats and IFAM, I want to thank you for joining us today.
Yeah, thanks everyone for coming.